Here at Union, you receive one-to-one care. You spend 1 full hour with a highly trained and experienced personal physical therapist. Schedule an appointment today and rediscover your health with Union PT.
Hello there, I am Mitch Owens. I'm the co-founder of Union Physical Therapy in Seattle, and I am joined today by Dr. Leslianne Yen from Swedish Sport, Spine, and Musculoskeletal Medicine in Seattle as well. So very, very pleased to be joined by Dr. Yen today to talk about sciatica. Sciatica is a very, very common condition, and Dr. Yen has a lot of expertise in this area, so very pleased to get to share this time with her as we go through and discuss some of the common questions that patients will have around sciatica, the symptoms of sciatica, and then how they are going to be managing this issue and then returning to activity, hopefully returning to sports. So thank you, Dr. Yen. And just a little bit of a history. I have a 10-year history of working with Dr. Yen, maybe more, but we'll just cap it at 10. And nothing but excellent things to say about her practice, her approach to medicine, her diagnostic skills, and the feedback that we've gotten from patients that have worked from her or worked with her. And so it's a pleasure to have you join me today. So thank you.
Yeah, thanks for inviting me. I look forward to it.
Great. Well, so we'll just start off by getting right into it here and just talking about what is sciatica.
So
go ahead.
Pain along the distribution of the sciatic nerve. So the sciatic nerve, I'm going to probably go ahead and share my screen at this point, just so we can have some visuals to go along with the words. All right, can you see this okay, this diagram?
Mm-hmm.
And can you see my mouse moving? Maybe not.
Yes, I can.
You can, okay, great. So the sciatic nerve is the name of a very specific nerve. This is a diagram of a right buttock. Low back is here, left buttock would be over here. And the sciatic nerve travels out from the pelvis and down the back of the leg, and it has multiple branches. And so strictly speaking, sciatica is pain anywhere along the terrain. Here that's depicted in blue, depicted in red, and on the side we can't see as well, up towards the front of the leg. It can be also in the top of the foot and bottom of the foot. But the sciatic nerve is made up of nerve roots from the spine. L4, L5, S1, S2, and S3 are the names of the nerves. And so you can have pain from sciatic nerve compression, meaning L5, S1, for example, in the spine, or you can have the same pain if the nerve's compressed anywhere outside of the spine. So that's what sciatica is.
Great. And then that covers some of the possible causes. How does sciatica most commonly present? You presented some options there in terms of anywhere along that terrain. But what's the most common presentation that you see that when that patient walks into the clinic, you're like, you have a classic case of sciatica?
Yeah, right. So there's definitely classic sciatica, and then what I call sneaky sciatica, and then there's nerve pain that's along the sciatic nerve that's probably not from the spine, which I give a different, more verbose name. But classic sciatica is kind of what we're all trained to recognize. And in fact, I tell people, if you post it on Facebook, all your friends will tell you this is sciatica. And that's what happens when you bend forward, you feel a zing that goes down the terrain of the sciatic nerve, meaning typically down the back of the thigh. And that correlates with a very specific pattern of nerve compression in the spine. But actually what I see most often is something I call sneaky sciatica, which is not a medical term. But essentially, it's sciatic nerve pain that does not, it's not so obvious. It's not necessarily worse when you bend forward. Sometimes it's better when you bend forward. Sometimes it hangs out just in the buttock or presents just in the foot. So actually, that's what I see most of the time, probably because the obvious classic sciatica is diagnosed by other people and they don't go on to see me. So yeah, there's a few different themes of sciatica, but the classic one is you bend forward, you feel a zing down your leg.
Got it. And then, so you feel like you see sneaky sciatica more often, right?
Yeah.
And so if we're going to talk about causes, what would you say would be the most common cause of sneaky sciatica, and then also just your run-of-the-mill sciatica?
Yeah, okay. So, classic sciatica when you bend forward, you feel a zing down your leg, is usually nerve compression in the spine. And the spine has two main zones in which the nerves can get compressed. And depending on which zone it's in, will determine whether it's classic sciatica or sneaky sciatica. So I'm going to go ahead and share my screen again, just so we can actually look at these pictures. All right, so here is a diagram of a low back, and we're looking at it from the side where the belly button is here, and the back of the spine's there. And the spine, of course, is made up of vertebrae that stack on top of each other, separated by discs. And those discs are responsible for propping open the windows, which is where the nerve roots in yellow travel out from the spinal cord, which goes down in that central spinal canal. We can't see that so well in this view. And as we age, those discs can become smaller. Instead of propping open the windows, they get smaller and the windows become smaller. And sometimes the discs bulge backwards, taking up space where the nerve should be. Sometimes we get arthritis and bone spurs in these joints called facet joints. And those bone spurs can project forwards, taking up space where the nerve should be. And so classic sciatica, where you bend forward, you feel a zing down your leg, is what people typically feel when the nerve is compressed at this window, what's called a neuroforamen. But if that very same nerve is compressed in the central spinal canal, which is typically one level up, then you get sneaky sciatica. And sneaky sciatica is where slouching often feels better. People often think of the grocery store sign. So sometimes you'll have a couple, they both have sneaky sciatica, and they'll fight over who gets the grocery cart when they're at the store, because slouching, and particularly when you're supported in that slouch, often relieves the pressure on the nerves when the nerve compression is in the central spinal canal. And usually in that case, the pain presents in the buttocks. It's usually not so much like a knife. Often it feels very muscular, which is one of the sneaky things about nerve pain, is most people are expecting numbness, tingling, or stabbing. And it's that numbness, tingling, stabbing is really the more severe tip of the iceberg. Most of the time you're dealing with the milder versions, which can feel like a linear ache or a deep soreness that's hard to relieve and sometimes harder to reproduce. But sneaky sciatica, actually there was a study looking at what's the best way to reproduce the pain of sneaky sciatica or lumbar central spinal stenosis in the office. And they did all these different physical exam maneuvers, and the conclusion of the study is that they were all pretty useless. And so patients who have, this deep buttock pain or this, aching pain that's really haunting them, and then they go into the office and they do all the maneuvers and they can't reproduce the pain, that's usually sneaky sciatica. And that's what I would say I see the most of when you're talking about nerve compression in the spine.
Got it. So it's somewhat hard to diagnose in a clinical exam then.
Exactly. Although the history is always what points you in that direction. It's usually actually pretty obvious.
Got it. Well, so let's say somebody starts to develop these symptoms. What would you recommend would be their very first best step besides fighting over the shopping cart?
Right. I think in Seattle, we're really lucky to have fantastic physical therapists. So I think particularly when you're talking about this sort of problem, it's always a good idea to start with physical therapy. I think among patients, it can be a joke like, I'm going to go see the doctor and they're going to refer me to physical therapy. And as long as there are no warning signs like pain at night, weight loss, a sharp focal pain in the spine where really imaging would be helpful and we need to look for other causes and pretty aggressively, that hardly ever happens. Most of the time, I would say 99.9% of the time, it's the type of nerve compression in the spine that would really benefit from physical therapy from the outset. So I would say physical therapy is a good thing to pursue straight away. Usually people notice improvement in my experience. Of course, you're the expert of this, but in my experience, usually people are noticing improvement within 6 weeks of PT. And then regular exercise is tolerated. So heavy lifting is more likely to provoke it, the bearing down, but staying active, walking if you can, when pools are open again, when it's not a pandemic, water walking, water aerobics is fantastic because you can get this multi-directional core strength, building endurance, also being stabilized by the water. Simple versions of mat Pilates, TRX, like suspension exercises, are all good low-risk ways to start to build back conditioning, which is one of the most important ways to stabilize the spine when there are nerves traveling through tight spaces.
Okay. So good advice, and thanks for the plug for PT. So with all of these different potential causes and some sneaky causes, what are your diagnostic tools, and what do you think is really your best way to diagnose sciatica? And then how accurate do you feel like that diagnosis is when you get to make it?
Yeah. So, how you make the diagnosis, number one is always the clinical history. That's by far the most important. So I spend a lot of time asking people nitpicky questions to try to get down to what it is. The reason why that's so important is because the physical exam is imperfect. We can't always reproduce the, 1 hour of sitting in the car that reproduces the pain. We can't necessarily do that in the office. And unfortunately, we also know that degenerative changes in the spine are very common in people who have no pain. And so if we rely on MRIs to make diagnoses, we are going to have a hard time separating out degenerative changes that are not causing symptoms from ones that are. So yes, that's how I start, is getting a sense for the history, getting a sense for whether it's dangerous or not dangerous, doing a physical exam, looking for weakness. And if a person's not improving with PT in time, or they're severely suffering from an acute disc herniation, then we would get an MRI. And always with an MRI, I like to call the pocket in advance. So in other words, I look at the pattern of the patient's symptoms and I say, that sounds like it's the L5 nerve, or that's the S1 nerve. And I judge based on the history, is this classic sciatica or sneaky sciatica? And most of the time I can kind of, based on that information, figure out this is L5 nerve compression. It behaves like sneaky sciatica, so I think it's going to be compressed at the L4-5 level in the central spinal canal. And then if we get an MRI and it doesn't show that, it shows something else random that's on the other side, or it's the S1 nerve or the L3 nerve, then we know that that actually is a negative MRI in terms of it not being the explanation for the patient's symptoms. So an MRI is helpful, but it needs context.
Got it. And so let's talk about this patient that you were just describing, that they've had their 6 weeks of PT, they haven't really seen improvement, or they've even, their symptoms have progressed further and they're a little bit worse. What kinds of interventions are you going to start thinking about offering this patient so that they can get over the hump and then PT is effective?
Yeah, so when a person doesn't get better with PT, really how we manage it depends on their priorities and how much they're suffering and what version of nerve compression we're expecting to see. And so, for example, in a case where it's pretty clear what it is, and the patient's really not interested in interventions, not interested in surgery or not interested in an epidural injection, for example, then really my first intervention is to figure out what's going right or not going right about what they're doing already. So are they being active? Do they have kids jumping on their backs? Are they not getting enough sleep? And try to treat those drivers first, make sure that the PT and the patient have a good relationship, and are they actually doing their exercises? So that's always my first intervention. If a person's really suffering, like a person has an acute disc herniation, they can't move, then we're going to get an MRI much sooner. And let's say we see exactly what we're expecting in that situation, a disc herniation where the jelly inside the disc is squirted out. And if the nerve is severely compressed, you have two options that I think are effective in that situation. One could be surgery, which is usually done through a little tube, minimally invasive and low risk, highly successful. The data is really clear. The people can be better very quickly, within a week or two after a appropriately done minimally invasive decompression. And sometimes one does an epidural. And an epidural injection is an X-ray guided injection of cortisone around the compressed nerve, with the idea that this poof of cortisone will decrease the pressure on the nerve enough to provide relief. And I think when I was training, the common kind of way of approaching epidurals is that you get an epidural, and if it makes you feel better, then you get another epidural, and you keep on going. And it kind of seems like a treatment, kind of like cortisone injections in the shoulder, a treatment with no particular destination, but something that's applied without as much thought as perhaps should be applied. And I don't really use it that way. I use it in situations where a person needs relief that's temporary. So the average relief with an epidural in some studies is 2 to 3 weeks.
Yeah.
So it's not a cure. And I think a lot of patients get the message that it is a cure. And so like, why don't we do an epidural? Maybe that'll cure me. But, that type of nerve compression is usually very much a structural issue with a mechanical overlay. And so an epidural does not improve your mechanics, and it also does not improve anatomy. So I don't use them as a long-term plan. I use it as a short-term tool. And so again, if a person has a lot of pain, they just need relief, we might use an epidural. Or if we're not confident or we're not sure, so let's say a person has mild, or not mild, but rather moderate narrowing around a nerve, and we're not sure if that's the source of their symptoms or not, you might do an epidural to see if it provides relief. And if it makes no difference, then you start looking for other locations or other explanations for the pain. And if it makes a huge difference, you feel a bit more confident that that is actually the source of symptoms. And usually that's a way of laying the groundwork as well for a surgical intervention.
Got it. And as far as the safety and efficacy of those two options, we're talking about the sciatica coming from a lumbar nerve compression.
Yeah.
What do you lean towards in terms of safety and efficacy? Are they fairly comparable, or kind of more like you said, it kind of depends on the situation for the patient?
Right. Well, so I mean, it's a bit apples and oranges in that one thing is a fix and the other thing is a kind of a tool. And so surgery, a minimally invasive decompressive surgery done by an excellent surgeon who's experienced with high volume, the rate of bad things happening is extremely low, like well less than 1%. Yeah. And that's based on my clinical experience where none of my patients have had a bad thing happen from the surgery when they go to see one of my favorite surgeons. And also it's in the literature that the rate of bad things happening is just very low.
Yeah.
With an epidural, I would say probably I've seen more adverse reactions with epidurals than the actual surgery. And nothing catastrophic, but I've had several patients who have a headache after an epidural, and that's typically, and a really bad headache, and that's typically due to what's called a CSF leak, when the fluid that bathes the nerves starts to leak out of the little puncture hole that was made with the epidural. And, that doesn't happen often, but in about 12 or 13 years, I would say I've had 2 or 3 patients have that. So, I'm not over eager to do epidurals. I think it's always important that the patient understand what that might do for them in terms of benefit rather than reflexively order it.
How effective do you think oral steroids are if your goal is to just try to buy them some time and a little space and improve mobility?
Yeah, that's a common question. The interesting thing about a course of steroids is that if you look at the data, and data is highly imperfect in all sorts of situations, but if you look at the research, the efficacy of a course of steroids is unproven. It's really surprising since people get courses of steroids all the time.
Right. Often the first line of defense.
And the reason why is it's easy and immediate, and what I meaning easy to prescribe and easy to take.
Yeah.
And the way I typically describe it to patients is that it's pretty much a Hail Mary pass. So I explain that the data does not support its use, but sometimes it makes a big difference in a situation where a person's in a lot of pain. And so we talk about risks and benefits, and then sometimes we'll use a 5 to 7 day course of steroids just to try to settle down the pain and make it somewhat more manageable. But it's really something I only use in patients who have severe pain. And most common side effects are irritability, stomach irritation. You shouldn't combine it with anti-inflammatories because that can increase your risk of an ulcer. Long-term use can contribute to osteoporosis, and people who have diabetes, it can increase the blood sugar around meals. So it's not without risks. There's certain rare side effects of bone having avascular necrosis, which I've not yet seen in a patient of my own, but there are some unpleasant things that happen or that you're at risk for when you use a course of prednisone.
Yeah. And then the results can be somewhat mixed, right? And that's what I've seen with my patients, is that some people do that course of oral steroids and do very well, and then I would say many more don't.
Right. It's again, I think just appropriate expectations and making sure that the patient has another option for pain, and not just using that as the primary tool. since the result of using a prednisone course is unpredictable.
Yeah. Do you feel like?
And unfortunately, sometimes people will feel better on their 5 to 7 day course, and then the course ends because you don't want to be on long-term steroids, and then the pain can kick back up again. So it's usually a bridge. It's kind of like epidurals. It's a bridge to something more definitive.
Yeah. Do you feel like age has an impact on the effectiveness of a course of oral steroids? Just the assumption being, I guess, it's kind of a strange question in that, like, the assumption would be that maybe the anatomy is a little better in a younger person, less DJD, less degenerative disc disease, that kind of stuff. But yeah, I mean, I guess it's going to vary tremendously patient to patient.
Yeah. I would say that usually the type of person I use steroids on is a younger person. And I think it's because the presentation is different. Like, an older person is more likely to have sneaky sciatica, that central spinal stenosis. It usually kind of creeps up on them before it's severe. In the cases where it's truly severe, like it kicked up because something happened, trip and fell, then I think those sudden exponential rising cases of pain are more likely to respond to prednisone. But I think it's more typically the younger folks who have an acute disc herniation and have this acute onset of horrible pain. I think that's the patient type that I'm more likely to prescribe prednisone in anyway, because it's the sudden horrible, 10 out of 10 pain.
Got it. And so in this, in the conversation we've had so far, we're talking about nerve compression as it exits the spine. Where else can we get similar symptoms in terms of that sciatic nerve being compressed?
Yeah. So actually, one thing I would be remiss in not mentioning is that people can have nerve compression in the spine from non-structural causes. So there are people who have terrible sciatic pain. It's definitely from their back. They bend and twist, and that hurts their pain. That reproduces their pain. And then you get an MRI, and they do not have a structural explanation for their pain. And that can be due to essentially what is sometimes called movement dysfunction. When the vertebrae are not moving relative to each other as they should, then you can just dynamically tether the nerve just from the positioning of the vertebrae. So I think that's a big thing to mention and for people to know about, because it can be frustrating to have terrible sciatica, get an MRI and have it be normal, and then feel like, now what does this mean? And usually that means you need good strengthening and a really good manual therapist to help restore normal motion. It's really common in people who are hypermobile, that they can bend themselves very far and that can dynamically narrow things. And if they bend and get stuck in a position, not physically, that they are visibly stuck, but just when you look at their vertebrae, if they're stuck in a position that narrows the nerves, that can cause severe pain too. So yeah, I just wanted to mention that too for all those people who have terrible sciatica and normal low back MRI.
Yeah. Yeah, that's good. And it's a good segue into my question about, so when you do see a patient who has, classic or sneaky sciatica and you're thinking about a referral to PT, what kinds of things do you like to refer or put on that referral? What do you want PTs working on? And I'll say also to this that Dr. Yen writes the very best PT referrals. I would say out of all the referrals I get, they're the most specific instructions that I think are salient. Like you'll get a lot of instructions on referrals that you're like, oh, that might be helpful. But, Dr. Yen's instructions are pretty much right out of the book and generally effective things to be working on. So I'm curious, for you to share what you like to have PTs work on in general.
Yeah. Well, man, I think the key thing that I've learned over time is that PTs know so much that we doctors do not learn about. So I think that's important to recognize at the outset, is essentially choosing the PT you're referring to well is 90%, maybe 99% of the prescription. But the things I look for on exam that I sometimes want to clue the physical therapist into is, are we looking at hypermobility as a driver? Do I think this is central spinal stenosis? If I think it's central spinal stenosis, meaning sneaky sciatica, then having a strengthening program that typically minimizes back extension and maximizes the patient's ability to maintain a neutral or slightly bent forward position, meaning building endurance of those muscle groups. So that's one thing I'll mention. And then, I think, manual therapy skills is hugely important. And I don't think a anyone needs a PT prescription to say that. If a person's a manual therapist, they know what to do as a physical therapist.
Yes.
And then the big things I look for is, do I suspect this is nerve compression outside of the spine? I think that's really helpful for anyone treating the patient to know about. And so that's something I parse out beforehand. Do I think this is actually not happening in the spine, but in the buttocks? And then I try to include that in the PT prescription.
Yeah. Yeah, and it'd be good to talk a little bit more about, compression in the buttock and the medical side of that. And then maybe we can circle back to some of the PT side of things. But I would like to just throw in a point of clarification, because you mentioned manual therapy, right? And for you and I, like, that's part of our dialect. We know what that is. And I think for our audience, it's really, can be rather vague, because manual therapy could be interpreted as a lot of things. So I'll just go ahead and define what I think manual therapy is. So manual therapy is really, it's an advanced form of conservative medicine where you're using your hands to not only diagnose, but also then to treat restrictions in mobility. You'll also assess areas of hypermobility, so areas where the vertebrae could be slipping or sliding too much out of position and tethering a nerve and grabbing that, creating those symptoms. You're also going to be looking at kind of regional interdependence is the term that we like to throw around. So we're going to look at the mechanics above and below and see how it could be impacting the area where the symptoms are coming from. So it's not just like massage or kind of feel good things with your hands. It's really an advanced form of biomechanical assessment and treatment. And I would like to say that, physical therapists and chiropractors, we're going to be the folks that have the most skill and training there. But not all PTs have that training. So that is something to look for in their credentials or in the training that they're doing in the office with that kind of peer-to-peer training. So with that, it would be good to talk about, entrapment in the buttock and what goes on there, where are the sites that we can get that nerve squeezed, and then we'll talk about intervention.
Yeah. So nerve compression in what we call the deep gluteal space or below the glute max is very, very common. In fact, if you Google Piriformis foam rolling, you'll see lots and lots of very fit people rolling around on their buttocks on a roller. And that's just, I think, speaks to how common this problem is. It's kind of like carpal tunnel syndrome in the buttocks, but it's under-recognized. I would say in my practice, it's actually way more common than carpal tunnel syndrome, although maybe that's an idiosyncrasy of my practice, but it's very common. And it makes sense if you think about the anatomy, actually. So let me pull up some pictures here. And we'll talk about that. All right, so this is a diagram of a right buttock. The low back is here, and here's the left buttock. And what we're looking at is this big yellow nerve. This here is the sciatic nerve, which, as we talked about before, is made up of multiple nerve roots from the spine, L4, L5, S1, S2. But most commonly, the nerves that people feel are L5 and S1. And essentially, after the nerves exit the spine, they then travel inside the pelvis, where on rare occasion, they can be affected by things like endometriosis or masses or bleeding from surgeries that people have had. That's very uncommon, but I do see it. And then the nerve exits the pelvis and travels in this space sandwiched between buttock muscles. And the big buttock muscle that I think most people think of when they think about the buttocks is the glute max, which they've peeled off here in this diagram. It starts off up here on the pelvis and comes down to the thigh bone. But if you lift that up, there are a lot of nerves there. And those nerves are sandwiched between the glute max and a bunch of other muscles. So when people do their clamshell exercises or they're working on their hip strength, if you focus too much on the glute max and miss all these other muscles, you're really missing something important, because weakness and tethering of the sciatic nerve in this space can contribute to sciatica. And typically when people have this presentation, what they notice is that they have pain often in the buttocks or anywhere along the path of the sciatic nerve. So some patients I have seen, they show up and they just have foot pain. They think it's plantar fasciitis or their arch hurts. It doesn't actually even have to be the entire path of the sciatic nerve. Sometimes it's a dotted line just in the buttock, just in the shin, just in the bottom of the foot. And those symptoms are usually provoked when they fire these hip muscles. And oftentimes the glute max and the hamstring, if you combine the firing of those muscles at the same time, that often will reproduce these symptoms. And so a classic would be like a hip hinge or a squat or going up and down hills, or people notice that if they're kind of in a kneeling position and they lift their leg up behind them and out to the side, that will reproduce the symptoms. And then the classic one is sitting. And what so many patients have come in and said is the absolute worst is driving, particularly if it's their right leg. They have their right leg out in front of them, pushing on the gas pedal. You'll even notice that as you lift your foot back, taking your foot off of the gas, the pain gets worse and better when you push down on the gas. And that's because if this nerve is tethered in this space, then you're sitting on it, and that further tethers the nerve, and the nerve has to travel further when you pull your ankle back, and it travels further when your knee is straight. And so that's a position that often will provoke these symptoms. And there are a number of things that can cause it. There is some research written on the causes of nerve compression here. Most of the literature is written by surgeons. So it's a very small subset of what actually exists with sciatic nerve compression in the deep gluteal space, because it's really just very few people who have symptoms bad enough that they're willing to go on and do surgery. And I would say, 99.9% of people who have this don't end up going on to have surgery, are not interested in doing surgery, and typically we can make them better without having to do surgery. But one thing that can drive it is hip muscles that are weak. So when you stand on one leg, if these buttock muscles as a whole are not strong enough, or if they fatigue because you're on your 8th mile, 15th mile of your trail run, then essentially instead of holding your pelvis stable, these weakened muscles allow the opposite hip to drop, and the muscles get pulled into a lengthened position, which then tense up the sciatic nerve, making it more prone to compression when you fire your glute max over top it. So going up hills again, and particularly when fatigue can cause compression of this of the sciatic nerve. And then on physical exam, what we typically see is a usual picture of sciatica, but with an added twist. And the added twist is that the part of the sciatic nerve that most commonly seems to get compressed is a branch that goes down to the lower leg and is responsible for lifting up your foot. And so what I see in these patients, and one way I distinguish this, is not only does it hurt when you sit, and not only does it hurt when you do like a squat and a hip hinge, but on physical exam, if they're sitting and their only weakness is lifting up their foot, what we call ankle dorsiflexion, for me, that's very localizing. If it's nerve compression that's in the spine, that's bad enough to cause weakness of the L5 distribution, you're not just going to be weak only lifting up your foot. So that's, I think, a useful pearl that I use all the time.
Yeah, definitely something I learned from you a while ago. It is very useful. So they're weak in sitting, but strong if you lay them down flat and there's not tension on the nerve. And I really like that you made the point to say that the nerve, it can be actively compressed because the muscles are too weak and they're over lengthening. And that lengthening or kind of giving way creates passive tension around the nerve, and then that's where you get your compression and irritation. Because like you said, when you go on the internet, you have all these pictures or videos of people rolling on balls, rolling on foam rollers, and just poking the spot that's already overstressed and sore. And so, the initial thought that most patients have is that, my buttock hurts, so I need to stretch it, or I need to go get some really deep tissue massage to release it. And it's in a very small percentage of cases that helps you, but in the rest of them, you may be, feeding the problem or even making it worse.
Yeah. Now, one thing that's really interesting that I see on ultrasound, so I didn't prepare any ultrasound images, but the nerve, so if my hand is the sciatic nerve, when your leg is relaxed in a neutral position, the nerve takes a pretty flat path. But when you're in a knock-knee position, because your hip muscles are becoming weak, or what we call dynamic genu valgum, it actually visibly tense up, and sometimes it even looks like a McDonald's sign. So when your hip is in a neutral position, it looks like this. and when you're in a knock-kneed position, it tense up. One thing I wanted to mention is that, I think a lot of things people do, whether they know it or not, they can be effective because they are treating the accurate root cause of their problem. So, for example, why does foam rolling help? Why does rolling on a lacrosse ball help? Essentially, those muscle layers are stuck together. If you go to a cadaver lab, they are literally adherent to each other. And so what you're trying to do is improve the glide of those fascial layers, those muscle layers, so that the nerve can better glide through them. And the key is just to not noogie the nerve itself. If it's already compressed, don't put that lacrosse ball right on the tender spot. Try to work around it. And one thing I've been recommending to people more frequently or more recently is a percussive massager. So you don't have to get like the most expensive Theragun that's like $500 with multiple different handles. But and CNET.com has a nice review of, what's the best value for your money for a percussive massager. But what I recommend is that people use that massager essentially around the nerve, not right on it. And it's the same idea that you're trying to improve the glide of the muscles and the fascial layers.
That's great. That's good advice. And, when I'm advising people to do, soft tissue mobilization for themselves, it's always pressure on, pressure off, pressure on, pressure off, because the surefire way to irritate the nerve if you are on the wrong spot is to sit there and sustain pressure. And there are definitely instances of people giving themselves sciatica by doing that. So just, get the layers moving, just like Dr. Yen mentioned. So we're talking about fascial layers, and what you've been holding back really skillfully is your very unique and special intervention that you do for sciatica that generates, or that addresses compression of the nerve between those fascial layers. That's hydrodissection. I was hoping that you could talk about how you use hydrodissection and some of the efficacy you've seen and which patients you like to select for that.
Yeah. So, everything we've talked about is how I start, with the patient. And for a lot of people, that makes a big difference. But hydrodissection is a pretty uneventful, often very effective, covered by insurance, not particularly painful injection that happens to sound gross, where we take fluid that's mostly IV fluid, so it's about 95% IV fluid and about 5% cortisone, and under ultrasound guidance, we place it under the nerve, and if we're able to, under and above the nerve, in that fascial plane where it's entrapped. And, the idea is really this is a mechanical intervention to accomplish a mechanical goal, which is to improve the glide of a nerve through a tight space. And, this can be really impactful wherever a nerve is entrapped. And there's a few reasons for it. So a common question that people ask is, one, are you injecting the nerve itself? No, absolutely not. We're trying to be very respectful to the nerve and make it happy. So we're placing fluid in the plane, the fascial plane where it lives, not into the nerve. And ideally, we want to put it where the nerve is entrapped, which sometimes it's really obvious, like carpal tunnel syndrome, it's entrapped in the wrist. But then in other places, like the deep gluteal space or in the buttock, there's a large zone where it may be entrapped. And we don't always have the option to treat it where we think it's entrapped. And we don't have perfect information to know where exactly it's entrapped. And so where I do the hydrodissection is where we can do it safely. So safety and experience is really important. There is at least one artery that's always next to the nerve. And some people get an extra dose of unlucky and have multiple arteries. So that's the primary concern that I have when I think about doing a hydrodissection, is looking for the things we don't want to poke and how to not make the problem worse. And the beauty of using fluid that's so boring, like mostly water and a little bit of cortisone, is that we can feel free to use plenty of it. That's why I use such a dilute version of cortisone, is so we can use 25, 35, 40 milliliters of fluid, placing it in that space where we can safely get around the nerve. And then once you're in the fascial plane of the nerve, the fluid travels pretty broadly along the path of the nerve. So today I did a hydrodissection. It went all the way from the sciatic notch down to the quadratus femoris, which is pretty broad. And that's nice because we can relieve pain that otherwise you're kind of stuck with if you don't get better with the other strategies. There's risk of infection, bleeding, poking things with the needle we don't mean to, like blood vessels, nerves, tendons. The rate of that happening is 0. I have had one patient out of 100 plus who has a new soreness from the injection, so it's not entirely without risk. And in these days, the primary concern is that you should not have cortisone within 14 days of a vaccine, like a COVID vaccine. So we're talking about that a lot lately.
Right.
But besides that, really the harms from the injection are pretty minimal, because the purpose of the cortisone is actually not to de-inflame things, that we're not using it as an anti-inflammatory, so we don't have to use much of it. The reason we're using it is to harness what's normally bad about cortisone, which is that it causes soft tissue softening. So we're using a very dilute version of cortisone to induce softening of the kind of adhesions and fascial layers that are tethering the nerves.
Great. Well, thank you for that explanation. And, I've had the pleasure of seeing patients that Dr. Yen has treated with this intervention, but then also I've been able to observe, and it is, approaching wizardry in my mind to watch you navigate those fascial planes through ultrasound. And it's, obviously have to be a very skilled individual using ultrasound to make that intervention work and have a very good understanding of the anatomy that you're working with. So yes, thanks for sharing about that unique intervention, because it's not done everywhere, right?
Yeah.
And we're, like you said, we're fortunate in Seattle to really, have a lot of great medical practitioners, so there are a couple of people doing the procedure in town. But I think if you got outside of a major metropolitan area with a great medical school and programs, training programs, fellowship programs, you might not see that so often.
Yeah.
So away from kind of the medical intervention side of things, the top tier approach, what are some common sense things that people can do to try to manage their sciatica? And one of the things that, came up in my searches, people were wondering, is walking good for sciatica?
Yeah, that's a good question. Yeah. So walking is good. One of my patients, actually, we did a hydrodissection, and he got on a plane and went on vacation. And he went to Europe, and he just walked and walked and walked, and he was better than he'd ever been. And it wasn't just from the hydrodissection, it was probably the movement afterwards that was really impactful. And he learned from that, and when he got back, he kept on walking. And essentially walking is really great because you don't have these very strong explosive loads through the glutes, and you're moving your legs back and forth, so you're gliding that sciatic nerve through the space. So I think that's really good. I think the other things, maybe it's premature in the conversation to talk about, but I think there are other things that drive nerves being happy and physiologically healthy. There is some evidence that anti-inflammatory type diets can be helpful. So, avoiding processed foods, essentially it's, fruits, vegetables, and avoiding processed foods is probably helpful for inflammation in the gut that may drive neuropathic changes. Alcohol is neuropathic or neurotoxic, meaning if you've been drinking a lot and you're starting to notice more tingling, that's something to stop. Sometimes people have a thyroid hormone abnormality or a B12 deficiency or excess can cause that. And then some people have, one nerve affected and then another nerve affected. There are quite a few people out there who kind of notice, like, my left foot tingles or aches, and how my right one is. And there are some peripheral neuropathies or systemic neuropathies that can present that way. So that's a reason to come in and be evaluated if you start to notice things like that. Yeah, the anti-inflammatory diets. And then I think the other thing that's worth thinking about is alpha lipoic acid, which is an over-the-counter medication that's been studied in 2 big clinical trials of diabetic peripheral neuropathy. And it's a low-risk way to decrease nerve symptoms. It's also an antioxidant. It's neuroprotective in some basic science studies. And that's a simple thing I often recommend to people. The primary side effect is it makes your urine smell weird. Some people say very weird. And I have heard just recently there's a trial going on where they found that when they use double the dose of alpha lipoic acid in patients with multiple sclerosis, that a very few people have developed a kidney problem. So I think staying at the right dose, 600 milligrams once a day, and if you are over 50 and have other medical conditions, then checking a urinalysis is a good thing to do. But those are kind of the mainstays of what I recommend for people. But yeah, walking, being active, and not a whole lot of sitting. So like a sit to stand desk is great. Good ergonomics is huge these days. Everyone's working from home and sitting at time and being less active. And so yeah, a good sit to stand desk, or at least a wobble stool where you can wiggle around a bit, keeps things moving.
Yeah, great. Well, that's great common sense, over the counter advice. I think one of the things that people will often wonder too is, how much to limit their activity. So we're talking about, okay, what are things that are positive forms of being active, like walking, you mentioned, or we talked about. What should people avoid, and can they make their symptoms worse if they try to push through them too much?
Yeah, the things that provoke symptoms usually involve sitting. So, cycling and pushing through your pain, long drives really are the main things. A whole lot of hip strengthening when you're feeling the pain, overstretching, sometimes can overdo it. But I think usually by the time I see people, they already know what provokes their pain, and pushing through it is unlikely to cause damage. Sciatic nerve compression for mechanical reasons usually does not, and actually I would say my experience never gets to the point that severe carpal tunnel syndrome gets to. Patients who have carpal tunnel syndrome, if they ignore it, the nerve can be permanently injured in a way that's not fixable if you later decide to do surgery.
Yeah.
In the average case of dynamic compression of the sciatic nerve in the buttocks, it never gets to that point. The only patients where I've seen damage, it's from something else, like a tumor or bad endometriosis. So I think pain is your guide. There's nothing that's really going to damage it. It's just going to make you suffer more, which can be demoralizing, but probably not harmful.
Okay, that's really good guidance. I wanted to ask too, just a timely question. So, we all have been sitting more. We've been less active during this period of, social distancing and this work from home shift. Have you seen an increase in the cases of sciatica that have come into your office? Have you seen an increase in any soft tissue injuries? Have there been any trends in the musculoskeletal world that we haven't seen at Union yet?
So I think there's just so much sciatic nerve compression in the deep gluteal space and so much nerve compression in the spine that I can't say I've seen at baseline. There always is. I can't say that I would notice a change in that.
Yeah.
What I have seen a lot of actually lately is neurogenic thoracic outlet syndrome because of the work ergonomics. So neurogenic thoracic outlet syndrome is kind of like sciatic nerve compression in the buttocks, except it's the brachial plexus in the neck.
Yeah.
And I just see a lot of it lately. And I don't know if it's something else. Sometimes it's referral patterns but certainly that's the sort of thing that tends to be provoked by bad ergonomics. So a lot of people are using their laptops and lying in bed or
working
sitting
on the couch. Yeah, exactly.
Have been protruding their necks forwards. But I think the bad ergonomics is driving a lot of worsening of this neuralgic pain in the neck, the shoulder blade area. People always have tension in their shoulders, tingling down the arms. So I think that's the primary trend I've been seeing a lot more of is thoracic outlet syndrome.
Okay, great. Yeah. So that brings me to the end of my list of questions that I wanted to ask. And I don't know if there was anything else you wanted to throw out there or any kind of PT style questions that you had, but
one thing I guess I'll mention, just because if someone Googles this problem, they would find piriformis syndrome.
Yes.
Maybe that's kind of acknowledging that this is what people most commonly call piriformis syndrome, which implies that a specific muscle in the buttocks called the piriformis is the root of all the problems.
Yeah.
And maybe I'll share my screen again just so people can see what is this so-called piriformis. So here's the sciatic nerve, and it goes under the piriformis muscle, which is this one muscle here. And the idea is that as the nerve exits the pelvis, it gets squished from above. I think that's really overly simplistic. There are multiple muscle groups that drive this. I think if we were to even pick one muscle, it'd probably be the obturator internus, which goes into the pelvis. But the literature is all about what's going wrong with the piriformis. And some studies describe it being too large and too small in the people who have this, which I think highlights the problem with blaming the piriformis is sometimes it's too big and sometimes it's too small. Some of the literature describes an atypical path of the sciatic nerve through the piriformis and the different branching patterns. And what is generally recommended in the literature is to inject the piriformis. And so, the recommended approach is to put some numbing medicine in the piriformis. That should relax the muscle, and if a person feels better, then therefore it's piriformis syndrome. And then you would follow that with Botox. I'm not a fan of that at all. And I think it's because most of the time the piriformis is not the problem. I think making a muscle that's important in the hip girdle weaker is counterproductive and really exacerbates everything else we've talked about, since having good functioning muscles is really important. I think usually it's an adhesion problem, that the nerve's stuck down, kind of like carpal tunnel syndrome again, where a nerve travels through the wrist and there's no muscle squishing it. It's just that it's tethered in there. So yeah, I think that's one thing I guess I would just mention, is that when people Google piriformis syndrome, it leads you to think it's the piriformis, and it can lead you down this whole path. And I think as common as piriformis syndrome is, or sciatic nerve compression in the deep gluteal space, I think there's what's written up about it is not very good. And I think there aren't that many people who treat it a lot. And so I think it does lead to these ways of treating it, which unfortunately I think are not that effective.
Thank you for mentioning that, because the idea of putting Botox in the piriformis just kind of drives me wild. I can't even really imagine taking out one of the more important biomechanical structures of the hip and pelvis.
Yeah.
So that's a great way to add gas to fire, in my view. So thank you for your time today, and I think we've gained a lot from this conversation. Anyone who's taken the time to watch this will gain a lot. We'll have learned a lot, and it's been a pleasure. So thank you. Thank you for joining me.
Yeah, thank you.
Welcome to Union Physical Therapy. At Union PT, we specialize in treating the outdoor adventure athlete.
Well, we treat all athletes.
Really? We just treat people.
Okay, so we specialize in fixing your body, no matter what your background or level of fitness is. We know what it means to be limited by an injury because we've been there ourselves. We understand the pain you feel when you're unable to do the activities you love with the people you love.
And no one wants to get left behind.
We know what a blown out shoulder means for your climbing season. We know not being able to do this is often more painful than the injury itself. And no one we know wants weak knees going into ski season. Here at Union, you receive one-to-one care. You spend 1 full hour with a highly trained and experienced personal physical therapist. We listen intently to you. Your treatment is tailored to your specific athletic work and life goals. We assess and reassess your progress with each visit. This allows your PT to rapidly refine your care plan and get to the root of your problem. One of the most important things we can provide you as physical therapists is an education. You will leave your treatment knowledgeable in the nature of your condition and how you can independently manage your issues in a way that fits your lifestyle. Whether you're a professional athlete, weekend warrior, or hardworking employee, we at Union PT are here for you. Schedule an appointment today and rediscover your health with Union PT.
Give me some more.